Hello, my name is Sam Ord. I'm an ICU doctor at Nepean Hospital in Sydney. And this lecture is about how to perform a focused cardiac ultrasound study. But I'm not going to do this on a real patient. What I'm going to try and use is the echo simulator from CAE Healthcare, and he's called Bob. And Bob has some great features that to try and explain some of sort of the three-dimensional aspects to doing a focused cardiac ultrasound study. I think when I started learning echo, it's almost like pattern recognition that helps you with each of the different images to try and get the correct view. Because as I've spoken on and sort of several times in the last few lectures, I talk about trying to make sure you sort of fan through the image in the correct manner so that you try and get the sort of the perfect view. I often describe it as sort of being down the gun barrel of the ventricle or something, and I think sometimes that can be hard to try and visualize when you haven't done it. And that's where Bob comes in, because he can show you with sort of augmented reality, or I can show you what the echo picture is at the same time of showing what the image looks like sort of on a dissected anatomical plane. And that's what we'll try and show in this lecture. And I'm going to try and sort of talk about a few tips and tricks about how to get the best imaging possible, because echo is very, very subjective, I find sometimes. And the more you do it, the better you're going to get. But it's important to have an idea of, if an image doesn't look quite right to you, have an idea in your head of what the perfect image should be and what movements you have to do to get that perfect image, or as near as perfect as you can. But we're going to be imaging critically ill patients, and they're not easy sometimes. And often you're going to find that some of the views you get are not going to be perfect. And unfortunately, that's the ball game. And you've got to do with what you've given. And sometimes that means we're not going to be able to get images in one plane, and that means you've got to move to another imaging location sometimes. And just do your best, and it does get better with practice, and you get to pick up more even if you've got bad images. And so maybe before we start, the last thing I'll say is, when you start, you're going to think that your images are terrible. I encourage you to store them, and then once you finish your study, go back and look at them, because often the information that you're going to want to glean from your focused cardiac ultrasound study, you can answer even with relatively poor images. Because remember, you're trying to answer binary questions. Is that LV dilated? Yes or no. Is it functioning normally? Yes or no. If it is not functioning normally, is it severely abnormal, mild or moderately abnormal, or hyperdynamic? Same for the right ventricle. And is there any large pericardial effusion that looks like it's causing any kinds of hemodynamic compromise to support the physiological diagnosis of cardiac tamponade? And then finally, trying to get an idea of what the fluid status is of the patient, whether they'd be fluid responsive. And as I said, that's kind of really sort of helps only at sort of the extremes, and kind of often sort of backs up what your clinical acumen is. So let's talk about how to do the actual imaging themselves. So first of all, it's how you hold the probe, and I encourage you to hold it like a pencil. I image from the left side of the patient, and that's because in the critically ill, you've often got lots and lots of tubes, and you've got lots of, they're intubated, and it's ECG cables and ventilator tubing, and often people trying to do things from the other side of the bed. So I image from the left side of the patient so that we can try and keep out of the way of everything that's going on. So you can image almost at the same time as resuscitation, if you like. I hold it almost like a pencil, and that's so that I can, with the back of my hand, I can rest that on the patient. Because when you've got gel and things being used, it can find it surprisingly easy to slide around. So I use the back of my hand as the anchoring point, and then I can put my probe on the patient, and I don't move around too much. The movements that I'm going to try and describe, we talk about sliding, and you can slide up or down, or you can slide right or left. And then when the actual footplate of the probe is resting on the patient, you can then talk about rotating, or we can talk about fanning, or we can talk about sort of tilting or rocking, and that's going from a more to a side-to-side direction. And this is obviously with the imaging plane coming down from the probe. And remember, we have a complex three-dimensional structure which are imaging with a two-dimensional imaging tool, which means that we must assess it in as many different angles as possible, and we have to sort of angle all the way through the structure to get an idea of the to get an idea of the motion. So we will be imaging in 3 main areas. We have our parasternal long axis view, which is going to be in about the 3rd, 4th intercostal space right next door to the sternal border. And we use that for our parasternal long axis, where we have the imaging, the dot that's on the probe, which points towards the patient's right shoulder. That's how to get the parasternal long axis view. Then we are going to rotate 90 degrees with the dot then pointing towards the patient's left shoulder, and that's going to give us our parasternal short axis view, where the heart looks like a donut. Then we are going to be putting our imaging, dot down towards the bed, and we are going to be pointing sort of up and here about the apex of the heart. So, you know, this is maybe sort of just down and left of the nipple, and we'll be again pointing up towards that right shoulder to try and look down the barrel in the 4-chamber view. And then finally, with the imaging dot then pointing towards the patient's left, we then put it in the subcostal position and sort of fan underneath the sternal edge, and that's called the substernal view. So we'll talk about each of those views in turns, and I'll just try and describe, using Bob, about how to get some of these images. Okay, so with the parasternal long axis view, your tendency when you're learning this is going to be you're going to be too far lateral. You're going to be too far away from the sternum. What we'll have a look here is I'll try and show you on the imaging screen here. So on the left side of the screen here, you can see that we've got this anatomical display, which I can dissect in various ways, which we'll do in a moment. And then on the right side, we get an idea of the sort of ultrasound picture. And the ideal picture that we want to get is where we see the mitral valve and the aortic valve, trying to get them opening up sort of together, where we're seeing the aortic valve in the middle of the screen and that mitral valve underneath it. And what I mentioned in the previous lectures is about trying to make that left ventricle as big as possible. So first of all, what I'm going to mean by that is I'll just try and play around with some of this. So this is what I mean about trying to get in right next door to the sternum. Okay, you want to try and get absolutely up in that sort of 3rd intercostal space, right next door to the sternum as much as you can. And that will give you the sort of best picture that you can achieve, where you've got the aortic valve and the mitral valve opening together. And here you can see the left atrium, left ventricle, and this is the LVOT going up into the ascending aorta. And normally this, I think the ascending aorta is sort of more of a gun barrel appearance, and I think that's just the way it appears on this simulator. And up here you've got the right ventricle. Okay, so that's where you want to be. Now, I talk about, I'm going to, sorry, just take away. Here this maybe gives you an idea of what we're actually looking at. So here we're sort of bisecting down through the heart, and here you can see that with the echo probe's pointer pointing towards the right shoulder, we can see that the patient's left side of the heart is on the left side of the image here. And what I want to try and explain is this idea of fanning. So I'll just take away the bones here. Now, I talk about trying to make this left ventricle that we've got over on this image here, on the echo image, about trying to make it as big as possible. And what I mean by that is that we've got to try and make sure that we are looking down the gun barrel of the ventricle. What I mean by that is if watching this program here, watching the sort of the anatomical image over here, if I image too far back, I can make that apex become sort of almost closed off. Okay? If I see it's being closed off, there are a couple of movements that I want to do. So if I see an image that looks like that, my first thought that I'm going to need to do is maybe do a little bit of rotation. So I'd rotate till that apex is opened out. Then I want to fan through it to try and make that ventricle as big as possible. And I'm going to encourage you to do one movement at a time. Either you fan or you rotate. You don't want to do two at the same time. And that's how you're going to try and make sure that that aortic valve is in the middle of the screen, that you've rotated it around so that you're not closing off that ventricle, you're opening it up as much as you can, And by fanning through, we make sure that that ventricle is as enlarged as we possibly can, which tells us that we are looking directly down the center of the ventricle, and we're not off to one side or the other in a tangential view or oblique view, so that if you're going to make measurements, you don't underestimate what you're making measurements of. If you see an image that looks like this, which is easy to see, if you see this, what we're going to be seeing is the tricuspid valve. And all I'm going to try and show you with this one is if I bring in it's very easy to accidentally be pointing too far inferiorly. Okay, this is pointing down too far towards the patient's right hip. And if you see that image, the movement you should be doing is starting to bring it back up to try and start seeing the aortic valve and the mitral valve. So if you're pointing too far down that way, seeing the tricuspid valve, you need to bring it back up. Alternatively, if you're pointing too far superiorly, you can often get an idea of this is the pulmonary valve that you can see just starting to come in. And if you see the pulmonary valve, up there, you know you need to point fan down a little bit, down pointing towards the more towards the patient's feet. If you want to look at the left ventricle, you can tip down a little bit more pointing towards the patient's left hip. Okay? So just have that idea of what a perfect picture needs to be in your head of seeing that aortic valve and mitral valve sitting in the center of the image, looking up that gun barrel of the heart. You do a little bit of rotating, trying to open up that ventricle as much as you can. So a little bit of rotating, opening up that ventricle as much as you can, and then fanning through it to open it up again as much as you possibly can. And when you've seen that ventricle at its maximum size, that's when you can start saying, yeah, I think I'm in the right plane here. If you're starting to think that you've got an abnormality in that image, again, if you see an abnormality in one imaging plane, you want to back that up in other imaging planes. So that's the parasternal long axis view. So to get the parasternal short axis view, I get the aortic valve sitting into the center of the image. And then with my right hand, I then take my imaging probe and I rotate it. So I'm not doing any other movement other than rotating it. And as I rotate it round and I finally get it pointing towards the patient's left hip, I then know that I should be on the aortic valve sort of short axis view. And by the short axis view, I mean that we are bisecting that heart directly across it and trying to do that in a perpendicular fashion. And so there you have the aortic valve view where you can see the three cusps of the aortic valve, the non-coronary cusp, the right coronary cusp, and the left coronary cusp. And what we then need to start to try and do is start to have a look down at the different levels of the heart. So we can look at the, let me swing it around like this. So we can then look at the heart, as we've bisected it, we can look at the mitral valve. We can look at the mid-papillary level. And then finally the apical level, where we no longer see the papillary muscles, with the posterior medial and anterolateral papillary muscles. The perfect view you'll be looking for in this short axis view is this beautiful circle, this beautiful donut, where you can get an idea of the global function of that ventricle as it's moving around. If you're seeing something that looks more like this, where it looks more like an oval, that tells me that we're making one of sort of two imaging mistakes. If you wanted to make if you were going to bisect it perfectly at a perpendicular level, you'll get that circle. You can either get this oval because you are rotated around it. So if you rotate it at a bad angle, you can get this oval. Or if you are imaging it sort of obliquely, again, you can get a more of an oval shape to it rather than a beautiful circle that we want. So what you want to be seeing is it bisected so it's absolutely perfectly spherical. So either you need to think that you need to rotate it to try and get that perfect. So either you need to rotate it till you start to see that perfect circle, or you need to look at trying to move up or down the axis of the heart. So here at the base of the heart, with the papillary muscle, the anterior and posterior mitral valve leaflet, excuse me. We then can slide down till we get the mid-ventricle level with the posterior medial and anterolateral papillary muscles. And then you have the apex. Okay, the next view that we have is we move down to put the marker of the probe pointing down towards the bed, and we come up to the apex of the heart. And this is probably one of the hardest views to start off with. We describe when we're talking about the left ventricle and the right ventricle function, we talk about making sure that we are not foreshortening the image. What I mean by foreshortening the image is being maybe a rib space too high and imaging off axis. Okay, we want to be imaging from the apex of the heart. And what I can try, maybe I can try and persuade you on this image that if we are imaging off axis, we can make this right ventricle look bigger than it really is, because it looks like it's almost the same size as the left ventricle in this image, because we are off axis. If I actually come from the right position, which is from the apex of the heart, looking up that sort of gun barrel of the heart, that right ventricle then looks 60% the size of the left ventricle, which is more appropriate and it's more normal. Okay? So here we can get an idea of the right ventricle, the right atrium, the left ventricle, and the left atrium. Now again, we've got to try and get an idea that if we see some abnormal features, what they are and what movements we have to do to try and get this sort of perfect view where at the apex of the heart, we haven't foreshortened it by going too high or too low underneath it. We want to make sure that we're imaging from the apex. The best way to try and do that is just to try and image up a rib space or try and image below a rib space. And sometimes simply you can't do it. And if that's the case, you've just got to try and get an idea that that you may be imaging off axis. Because as I was talking about in the right ventricle lecture, if you do see a dilated right heart, I want the first thought to be in your head is, am I imaging it incorrectly? Does the fact that I can see a dilated right heart in this view, is that backed up in my subcostal view or my, my short axis view? In terms of if you're seeing some abnormal features if you're not getting this perfect echo image, how do you get it? One of the sort of most common things is that you point too far up. And that's where you start getting what's known as the 5-chamber view, where you can see the aortic valve starting to come in, which is this structure in here. If you see that aortic valve coming in, what you need to do is you need to fan down, and then you'll see it disappear. Okay? One of the other things that you can sometimes see is if you image too far posteriorly, you get this black line that comes across it. And this black line that comes across it is the sagittal sinus that you're seeing. And if you're seeing the sagittal sinus, again, what you have to do is you have to image further forward. And maybe I'll just ask you to look at the angling plane between me being too far anteriorly and getting the 5-chamber view, and being too far posteriorly and getting the sagittal sinus coming into it. And that's probably a difference of maybe 15 degrees. And this is one of the frustrations of echo, which I'm sure you'll probably start to know and love, is that very small movements can make a big difference when you're imaging someone's heart. And that's why it's important to have some kind of anchoring of the probe on the skin so that you're not sort of flying around in the wind, and you can make small adjustments and you can do small fanning movements, and you try and get the image sort of as perfect as you can down the gun barrel of that ventricle. So there we are. So imaging right up from the apex of the heart, looking up that gun barrel of the ventricle. You don't want to be too far forward, you don't want to be too far back. And just making small little movements of rotation or fanning can help give you that sort of perfect image. And again, persistence is the key. Just for those of you getting sort of a bit more advanced with the imaging, if you wanted to move on from a 4-chamber view to a 2-chamber view, what you have to do is move the echo probe. You're going to rotate it about 60 degrees, and that's in a anti-clockwise direction. And the way I do that is I go from being in my apical 4-chamber view, where the sort of septum, interventricular septum, is right down the middle of the image. I move it so that it's I sort of angle round, so that you've got what's known as an LV centric, or the LV is in the middle of the echo image. And then I rotate slowly, 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 rotate round about 60 degrees. And once you've rotated around about 60 degrees, so that's where you've gone from your 4-chamber view. I then rotate around 60 degrees, and that will then give you your 2-chamber view. And here we're looking at the inferior and anterior portion of the heart. Okay. So now finally let's look at the subcostal position. So image marker pointing towards the patient's left, about sort of the 3 o'clock position, I guess. And we angle underneath the rib cage. Okay, so I'm angling underneath the rib cage. And by angling underneath the rib cage, we can look up underneath using the liver as the acoustic window. We can look at a subcostal position. Now the perfect view that we were trying to get with this is looking at the 4-chamber view again. So we're looking down the barrel of that ventricle, trying to make that ventricle look as big as possible. And by that I mean that you're not tangential, you're not off axis with the heart. And if you're seeing something, if you're seeing the aortic valve, again, like you're looking at with the, again, like we were saying the apical 4-chamber, if you see the aortic valve coming in, we know that we have imaged too far anteriorly. So if you see the aortic valve, we know that we've got to fan backwards, we've got to point more posteriorly. And again, we do one movement at a time. So if you see the aortic valve, we move back a little bit, and then we can start to do little bits of rotation, trying to make that ventricle look as big as possible. If the apex of the heart is sort of off to one side and you can't see the apex of the heart, what do you have to do? Well, you know that you've got to sort of angulate it round, you've got to rock it round so that you can look from looking over there. We know that we can look over that side, point towards the probe towards that patient's left shoulder. And then if you see the aortic valve in, we've got to fan it back a little bit, and then we're going to rotate it round. And we rotate it round too far, and we see that we've closed off that apex. We rotate it too far the other way, we've closed off the apex, so somewhere in between, so little bits of fanning, little bits of rotation, one at a time, and there we're sitting on it. And we know that we're sitting down the gun barrel of that left ventricle. So what about the vena cava? So if we want to have a look at the inferior vena cava, the way that I do this is, first of all, I fan through the heart. I fan through until I see a sign of something coming into that right atrium. Okay, so I just fan it through until I see that point. When I see that point, I then bring that into the center of the screen just by doing some gentle rocking. Once it's there in the center of my screen, I know that when I rotate, whatever's in the center of my screen will then be in the center of my screen as long as I rotate. And suddenly I can then see, I can absolutely be certain that I'm imaging that IVC. I can see that IVC RA junction, and I can see it perfectly in sort of longitudinal format. And again, just little bits of fanning through it, make sure that I'm imaging it sort of as tangentially as I possibly can, so that I'm not too far off, so I can make the IVC look small or small. I'm absolutely imaging down in the center of that IVC. I kind of describe this movement as a bit like if you're putting in a central line into the IJ, that if you want to move it from being a perpendicular view where you're looking at a circle and you want to look at it in a longitudinal format, again, you bring that IJ into the middle of your screen and then you rotate it around very closely, watching it as you do. And this is a similar kind of format where you've got that IVC-RA junction. So we look at the subcostal view, you fan through till you see that IVC-RA junction, which you're seeing just there and just down there. You bring that into the center of the screen by rotating it around, and then rotate, and you know, if you keep that in the middle of the screen, you'll eventually be sitting down there, down the gun barrel of the IVC. So that's it. That's just, I guess, some of the, just to get some of the ideas of the three-dimensional structure of the heart, and when we talk about fanning through it to try and make sure that you're seeing that ventricle in its maximal diameter, or when you're imaging from the apical view, trying to make sure you're not foreshortening. I hope that just kind of gives you an idea about what it is that people are talking about. I think some of in terms of the tips and tricks about how to actually image a critically ill patient, one of the other movements that I find is probably one of the most important things is talking about sort of nestling into that intercostal space. It's actually providing sufficient pressure. And you want to, obviously, you're not trying to image their vertebrae or something, you know, but just try and find your way into that intercostal space and just provide a little bit of pressure just to get into the sort of the muscle of the intercostal space, and that will help your imaging. The tendencies when you start to image are going to be that you will be too far lateral when you're taking your parasternal images. You will be too far medial when you take your apical images. So make sure that you're sitting right next door to the sternum on your parasternal. Make sure you're sitting lateral enough on your apical. Make sure you've got that interventricular septum down the middle of your image, and try to avoid foreshortening by going down a rib space if you can, to try and make sure that you're right at the apex of the heart. And then in the subcostal regions, providing enough pressure, so obviously you're not, again, trying to image their vertebrae, but trying to provide enough pressure so that you can hold that probe flat and sort of imaging up underneath of that rib cage, and trying to make sure that you are not imaging off axis. And other than that, it just takes a little bit of practice, and you know, it's frustrating to begin with, and the images are never exactly as they appear in the books, and that's unfortunately the ball game. But it does get better with practice. Classically, they say maybe 20 to 30 focused cardiac ultrasound studies, and you are proficient in getting the images and knowing what you need to look for. And it's an incredibly useful tool that gets you out of trouble sometimes. It can help pick up life-threatening abnormalities, but I think more commonly it just adds maybe confidence to your clinical acumen, and it's a non-invasive, at-the-bedside tool that has become a big part of my practice, and I think it's a useful tool to learn, and I hope you do too. So best of luck.